Thank you, Manoj Boss. Welcome after the tea break. Since it's IPL season, this is not my original idea. Arthur Singhi stole the theme first, so he sent his title first, so I just followed suit. But I think it's a good analogy because what I'm going to talk about in the next 40 minutes or so is how the management of gastric cancer is changing and changing very fast. And because of the mixture of audience, some trainees, some practicing pathologists, some senior members, it's going to be a little bit of everything. So just bear with me. If it's too simple, just hold on for a few minutes and you'll get to a part that you might find interesting or new. So So why do we care about gastric cancer? One, or why do we care about gastric cancer in the West? Not really a common disease there. We see a lot because we are at a dedicated cancer center. But overall, if you look at incidence and mortality on the globe, India is somewhere in the middle, not really a very high incidence area like the Far East or Russia or parts of South America, but not quite like the West, where at least a subtype of gastric cancer has been declining, as you can see here. So from the mid 70s to 2019, you can see this dramatic drop in gastric cancer in the US. And this is largely due to the fact that gastric cancer in the most common variety is the prototypical inflammation to metaplasia to carcinoma sequence. So since Helicobacter has been identified and can be treated, in the West, the incidence of gastric cancer declined in parallel with the decline in Helicobacter gastritis. So before we get into gastric cancer classifications and therapy, first things first, how do we define gastric cancer, or what is gastric cancer? So it sounds very simple that, gastric cancer is carcinoma of the stomach, and that's true and easy unless the tumor involves the GE junction. So this is something for the trainees to remember. If you get a specimen, a gastrectomy specimen, in which the tumor is involving the GE junction, you have to do a few things. One, measure the size of the tumor and see where the center of the tumor is located. And so you can see this is the current CAP guidelines and the HACC guidelines on how you define gastric cancer. So if the epicenter of the tumor is more than 2 centimeters away from the gastroesophageal junction, then that qualifies as a gastric cancer. So you have to use the synoptic for gastric cancer, even though it's involving the GE junction. If the same epicenter is less than 2 centimeters from the GE junction, then you stage it using the esophagus GEJ template, and it's staged largely as an esophageal carcinoma. The exception to the rule is that if the epicenter is less than 2 cm, but the gastroesophageal junction is uninvolved, then you still stage it as gastric cancer. And the reason for that is that the data predominantly comes from the West, and cancers of the proximal stomach are more likely to be distal esophageal cancers that grew and involve the proximal stomach. And which is why I think you need more studies from the East to really refine this classification. It sounds very crude that if it's less than 2 centimeters, classify it as esophagus, more than 2 centimeters, classify as stomach. But that's what you have to do. So a few things: locate the G junction, measure the tumor size, see where the epicenter is, note the distance from the gastroesophageal junction, without which you cannot fill out the template properly. So why do we care about tumor classifications? We care because they give you a glimpse into underlying etiopathogenesis. Is this more likely to be inherited versus sporadic? What are the predisposing risk factors? Most classifications have some kind of a prognostic significance. And then, as I'll mention in the last 10 minutes or so of the talk, gastric tumor in particular, the classification is moving. We are becoming more like hempath, and I'll tell you why. So this is how we have classified gastric cancer historically. There's a gross classification. If you recall the synoptic templates that we have to fill out for gastric cancer, there's a gross Borman's classification. There are histological classifications that have stood the test of time, are very helpful in some ways, which I'll talk about. Loren and WHO are the ones used most commonly. There are a number of others which are not widely used, but are used within certain geographic zones. The Japanese have their own classification. Since 2015 or so, there have been a number of genomic profiling classifications. I'll share one of them with you. And then what has really taken off is a biomarker classification of gastric cancer. And we'll talk a little bit about that towards the end. So macroscopic classification or endoscopic classifications are very useful if you have gastric surveillance programs and you detect early lesions. And they're important because just looking at the lesion gives you a sense of how likely it is to be invasive. And we won't go through each category, but in general, the more polypoid and projecting into the lumen kind of a lesion, the less likely there is an invasive underlying component to it. And the flatter and also more ulcerated the lesion, the more likely that there is going to be a deep invasive component. So as first principles in both esophagus and in stomach, the endoscopic appearance of the lesion and then an endoscopic ultrasound basically decide what happens to the patient. If there is no deep invasive component, those patients get treated by endoscopic resections, whether in EMR or in ESD, and I'll talk about it a little bit. And then if it's a deeply invasive lesion, then the triage or the algorithm goes more towards neoadjuvant therapy followed by surgical resection. So very helpful in deciding which patients need an endoscopic ultrasound before you start nibbling. You can take a biopsy, but you don't really attempt a resection unless you have done a proper evaluation. Lorentz classification into intestinal and diffuse has been around for decades. This is from the original paper showing that you can broadly define two groups of gastric carcinoma, one intestinal, which essentially is a mass-forming lesion. And if you take sections from that tumor, you see gland-forming tumor, the conventional adenocarcinoma. Whereas this other type, you don't really see a discrete lesion. You see prominent gastric rugal folds on the picture on the bottom right. So you can't really see a dominant mass. And this is the linitis plastica, leather bottle stomach, whatever you want to call it. And on histology, there is single cell infiltration. These tumors don't really form glands, and which we used to call signature cell carcinoma, which has been a bad term to use for decades. And now we're in the process of trying to fix it. So why is Lorentz classification very useful? It's very useful because it gives you two distinct groups of gastric cancer. One really associated with H. pylori, which is the typical intestinal type, also in other inflammatory conditions like autoimmune gastritis. So this is the prototypical inflammation to metaplasia to dysplasia to carcinoma kind of a cancer, as opposed to the diffuse type, which arises de novo. So it's either inherited germline defects in CDH1 or acquired sporadic defects. Intestinal type more common in male, diffuse type more in female. The incidence graph that I showed you, that's declining incidence of gastric cancer in the West, is almost all intestinal type. The reason we are more interested in gastric cancer in the past decade or so in the West is because the incidence of diffuse type gastric cancer, for reasons we don't know, is actually increasing, and that too in young patients. And then the patterns of metastasis are a little different. Intestinal type typically goes to visceral sites, diffuse type, more the peritoneum and ovaries. So for trainees, the typical or prototypical Krukenberg tumor is diffuse type gastric cancer going to the ovaries. And then, as I said, there have been a number of attempts at histological classification because the morphology of gastric cancer is very heterogeneous and you don't really know to memorize all of them. The one that's most widely used now is the WHO classification. So I'll run through some of the morphological patterns of the simpler and more common types, and then focus really on two or three morphological subtypes that are rare, uncommon, but I think you need to know about them. And they are really the ones that have some prognostic significance, because the rest that really depends on stage. So whether it's tubular papillary, tubular papillary, well diff, pole diff, doesn't really matter that much. So this is what tubular type means, that the tumor cells form glands, hence an adenocarcinoma. You can have two types of differentiation: intestinal type, that it looks more like a colon adenoma. Gastric type retains the gastric type mucin. Usually, most gastric type tubular carcinomas are early stage. As the tumor gets more and more deeply invasive, they'll transform to the more intestinal type. So it's a rare pattern. You'll see it more often if you have an endoscopic surveillance and screening program, or you have gastroenterologists doing endoscopic resections. There can be different grades of the same tubular type carcinoma. So remember, we grade GI adenocarcinomas in general using percentage gland formation. So there's a spectrum where virtually the entire tumor is forming glands to those tumors that are predominantly solid. They're not forming glands. So when you're filling out your synoptic template, sometimes it's confusing as to where to put it. Is this WHO tubular or papillary? Because the tumor is almost all solid. And those are poorly differentiated tubular types of gastric carcinoma. So here's a good example of papillary. As the name implies, they are finger-like or villous projections, fibrovascular cores lined by neoplastic cells. And again, there's a spectrum of differentiation. So in general, as a general rule in pathology, you type tumors based on the most differentiated or the best differentiated part, and you grade them based on the least differentiated part. So if you have a tumor where much of the tumor looks like this, it'll be a moderately differentiated tumor. A well-differentiated tumor will be where more than 90% of the tumor is forming some kind of tubules or papillae. And then, like in any other, as I said, gastric cancer morphology is very heterogeneous, and hence there is no real classification that carries prognostic significance to any meaningful degree. So here's an example where you have both tubules and papillae, and so this is the tubulopapillary architecture of gastric cancer. And then, as I said, the diffuse type is usually single cell infiltration. We used to call them signature cell type, still do, because the most common pattern of this tumor is eccentric nuclei with a dominant mucin vacuole. So it looks like a ring. The reason it's not a particularly good name, especially in context of the stomach, is that not every tumor will have mucin. So you can see examples on the right that are the same underlying CDH1 mutation, but they don't really have mucin. So some of them have very eosinophilic, abundant cytoplasm, almost a rhabdoid kind of a morphology with prominent nucleoli. Or examples here where these are all tumor cells. So this is the same spectrum of tumor genetically, but looks very different morphologically. So which is why there was this switch led by Fatima Carneiro, a fantastic gastric cancer pathologist in Portugal. And she's been integral in bringing this term poorly cohesive carcinoma into the WHO, which encompasses signature cell carcinoma also. So just remember that poorly cohesive carcinoma, signature cell carcinoma is a type of poorly cohesive carcinoma, and not all poorly cohesive carcinomas will have a signature cell morphology. And then you can also get mixed intestinal and diffuse type. So here's a tumor that's almost 50-50, forming glands and also doing the single cell infiltration. So this is mixed tubular and poorly cohesive type. So this is the probably, if you're filling out a gastric cancer synoptic, this will probably be 95% of the time, it's going to be one of these patterns. And then mucinous, as the name implies, just like in the colon or at other sites, the bulk of the tumor is going to be pools of mucin in which there can be floating strips of neoplastic epithelium or clusters of neoplastic cells that have, again, a signature cell morphology. So often trainees will mistake this for signature cell carcinoma, and that's not accurate either. So goblet cells are signaturing in morphology, right? But we don't use signature cell carcinoma for that phenotype. So if you have abundant pools of mucin with floating tumor cells, that's a mucinous adenocarcinoma. And again, it's the percentage rule. It has to be more than 50% of the tumor. I want to just say a quick word about an interesting and important advance in neuroendocrine carcinoma diagnosis. Some of you may know it, many of you I'm sure don't. Gastric cancer, just like any part of the GI tract, most neuroendocrine carcinomas of the GI tract arise as divergent differentiation in a pre-existing adenocarcinoma or a squamous cell carcinoma. They don't, so this is not lung. They don't arise de novo. And if you look at the genetic signatures of these tumors, they are more like adenocarcinomas, not like the typical neuroendocrine carcinoma of the lung. And you can see examples where this is really happening. So you caught a tumor in transition where you see both components. Part of it is a gland-forming adenocarcinoma, and part of it is a poorly differentiated neuroendocrine carcinoma. So you can see a very nice example here. This is a biopsy where on the right half, this is tumor-forming glands. On the left is a poorly differentiated tumor, which looks just like small cell carcinoma of the lung. So why do I bring this up? Just to share something which really came about from colleagues of mine in thoracic pathology at Memorial, which is that we've known for decades that there is a subtype or subset of small cell carcinomas that really don't stain. They look prototypical small cell carcinomas in the lung, but they don't stain with neuroendocrine markers, chromogranin or synaptophysin. And at Memorial, the practice had always been to treat them like small cell carcinoma, but we know that there's a big differential, that there are other carcinomas that can look similar. So there wasn't really a marker that helped us identify these so that they can be treated appropriately as small cell carcinoma and not a polydif adenocarcinoma. And through gene expression profiling studies, they identified PAU2F3, which is a chemosensory tough cell marker in the lung. And PAU2F3, interestingly, is also present. Neuroendocrine cells in the gut express PAU2F3 because it's a chemosensory endocrine cells, which is responsible for sensing parasites. So it's present also in the GI tract, but we didn't know about it. And you can see on the top examples on just regular H&E that look just like small cell carcinoma. But if you look at chromogranin and synaptophysin, this is the prototypical example. But then all these others are negative for chroma and synapto. But if you had the antibody for PAU2F3, you can see this is a very nice, robust nuclear stain that stains this neuroendocrine marker poor or negative small cell carcinomas. So I'll just share a cool example, again, from the proximal stomach, a mixture of gland forming and solid components in the tumor. So this would be, if you only had this, it would be an adenocarcinoma. If you have this solid component, then it looks like a polydif. Whenever you see a polydif tumor in the esophagus or stomach, the differential really is 3 or 4. It's either going to be a polydif squame, a polydif adeno, a polydif neuroendocrine carcinoma, or an undifferentiated carcinoma. There are some rare things, but that covers 99.5 out of 100. So if you have a tumor that looks like this, usually you'll do a P40 for squamous differentiation. You'll do maybe a CDX2 for adeno, but usually that's a diagnosis of exclusion. And then you do your chromogranin synaptophysin for neuroendocrine. But if it's negative for all, and it looks neuroendocrine like the case here, then it's important to think about PAU2F3. So here's a good PAU2F3 stain showing that it's negative in the gland-forming adenocarcinoma component like you would expect, and it's positive for PAU2F3 in the neuroendocrine carcinoma. So this can then be treated with, it's not that important in the upper GI tract because they still get platinum-based therapies, even if it's a polydif adenocarcinoma, but there's a little change in the chemotherapy regimens that they use if you say it has a neuroendocrine carcinoma component. So just something to remember, which is new in the past 5 years or so. And then you can see a lot of lymphocytic infiltration in tumors, and these really are a differential of 2. It's either going to be an MMR deficient or DNA mismatch repair deficient tumor, usually loss of MLH1 and PMS2 because these are sporadic hypermethylators, or it can be an EBV-associated adenocarcinoma, which we don't see too much in the West, but it's not that uncommon in the East, particularly the Far East. And then the way to make that diagnosis is to do an ISH for EBV, and you can see this nice nuclear positivity in the tumor cells. But we did many years ago a study with colleagues in Korea and showed that what we used to call the classic pattern lymphoepithelioma-like carcinoma, which is figure A in this panel, where it's actually very hard to identify the actual tumor cells. Most of this is non-neoplastic lymphocytes infiltrating the tumor. So that was the prototypical EBV-associated carcinoma. But if you screen a series of gastric cancer in an endemic area, you can see that it's not always the case. So you can actually subdivide the morphology of EBV-associated gastric cancer into 3. Those that have the prototypical lymphoepithelioma-like carcinoma appearance. For those who want to picturize in your head, think of nasopharyngeal carcinoma, where you have more lymphocytes than tumor cells, and it's hard to pick out the actual neoplastic cell. Then you can see what we called, at least in this paper, Crohn's-like infiltrate, where you have these big lymphoid aggregates in response to the advancing edge of the tumor. And then those that had a really minor lymphoid component and look like garden variety adenocarcinomas of the stomach. And if you look at prognostic significance, this is a better example showing you a panoramic view of the carcinoma on the top, which was positive on EBER-ISH, and you have this Crohn's-like infiltrate, just like you would see in a colon that's Simplo or KRAS mutant. And if you look at prognostic significance, you can really see that the better prognostic significance of EBV-associated gastric cancer is restricted to the lymphoepithelioma like carcinoma subtype. So they have the best prognosis, and tumors that are EBV driven but don't have a lymphoid response really tend to behave just like garden variety gastric cancer. They don't really have the same excellent prognosis that we associate with EBV. Two subtypes, or maybe three, that have independent prognostic significance, which we should know about. The first is micropapillary, which, as the name implies, has this peculiar architectural formations, which I'll show you a higher power in a second. It's an adenocarcinoma. It's seldom present in pure form, usually as a minor component of a gland-forming tumor. So you can see a conventional adenocarcinoma on the left, and this is all micropapillary differentiation. And why do we call them micropapillary? We always tell our trainee these are silly or stupid tumor cells that have forgotten how to make a gland. So they're making a gland on the outside rather than the inside. So that lumen is a real space. And this inverse polarization or reverse polarization, where the brush border is on the outside as opposed to the inside, is very peculiar and typical of micropapillary differentiation. So they look like papilla, but they don't really have a big fibrovascular core in the center, and hence the word micropapillary, which we borrowed from the GYN people. You'll hear a lot of micropapillary tomorrow, I'm sure. The reason it's important is that unlike every other subtype where we need 50% of tumor to classify it as that particular subtype, for micropapillary, the cutoff is just 5%. And that tells you that this really has independent prognostic significance. It has a propensity for lymphovascular invasion much more than the other subtypes. And when you see this, the other challenge is that there is no way that you can actually differentiate this pattern from lymphovascular invasion, because the space looks real. There's usually a fibroblast lining the stroma around it, so it can look very much like there's tumor floating in a lymphatic endothelium. There are some clues on morphology, but none are absolute. So you can see that here's an example of micropapillary on a CD31. So it's all micropapillary, no lymphovascular invasion. And here's an example of a D240 stain where you can see nice lymphovascular invasion, but then other parts of the tumor that are not really, they have a space, but it's not really micropapillary. And so why do we care? It's a rare subtype. The first series we put together was just 11 cases. You can see what I just said, that micropapillary differentiation was 5 to 70%. So in the colon also, that's the cutoff that's proposed by WHO. Very high prevalence of lymphovascular invasion, very high prevalence of nodal metastasis. So an aggressive subtype. So anytime in the GI tract, whether it's colon or upper GI, if you see a T1 or T2 early stage tumor that has gone to the nodes, if you look carefully, chances are you'll find a focus of micropapillary differentiation, which in the colon now we call solid cell clusters and other fancy names, but it's basically the same phenomena. And you can see the prognostic significance here. And as tumors advance and go to nodes or distant sites, whether it's conventional or micropapillary, you lose the prognostic significance. So you can see here that if you only look at stage 1 or 2, the micropapillary ones tend to do much worse. And once the tumors are very advanced, then you lose that prognostic significance. So if the tumor is already in the liver or lung or bone, whether it's micropapillary or not, it's not going to matter. But if it's confined to the mucosa or submucosa, then whether or not it's micropapillary has huge prognostic significance. Another very rare type, which is, if you've been following the gastric cancer literature, there's a controversy between the Japanese and the Americans, not very surprising. Initially described by the Japanese as gastric carcinoma with cheap cell differentiation, renamed by Liz Montgomery and her colleagues in the US as actinic gland adenoma. And as always, the truth lies somewhere in the middle. You can see both. It's neither always benign, neither always malignant. It's more like a precursor that progresses in a small proportion of patients to an invasive carcinoma. So in the benign end of the spectrum, it's basically form of actinic gland with a little abnormal architecture. So these are polypoid lesions in the stomach This is not a funded gland polyp. It's a true precursor of gastric cancer. And when they progress, you can see the architectural disarray, irregular glandular profiles infiltrating the stroma with this loose desmoplastic response. And the reason they are peculiar is because you would expect carcinomas to lose differentiation, right? So these are peculiar cancers that retain chief cell differentiation. And if you look carefully, you can actually see parietal cells. So there are subsets the Japanese have reported is parietal cell adenocarcinoma or chief cell adenocarcinoma. Again, um, you'll only see this if you have a surveillance program and people doing endoscopic resections for early tumors. The same tumor, if it's a T3 or T4, it'll change phenotype as soon as it's going through the submucosa and the muscularis propria. So just something for you to remember that there will be a subtype of gastric cancer that will retain the lineage from which it arose. If it arose in the oxyntic glands, a subset will keep forming chief cells and parietal cells. These, if you want to stain, they stain with MUC6, which is a marker of pyloric glands, but also marks chief cells in the oxyntic mucosa, but will also stain with pepsinogen as it should, since it's chief cell differentiation. There's a category, I don't like calling this a subtype because I think it's been called so many different names in literature that it's lost its significance. It's been called introblastic, it's been called hepatoid, it's been called clear cell, it's been called yolk sac-like, and I'll show you why. Again, gastric cancer, very common in Japan, so much of the early literature and interesting stuff comes from them. The reason there are so many names is because it has a broad spectrum of morphological patterns. So here you can see something that looks predominantly clear cell type. On the right, you can see nested or cords or broad trabeculae with very eosinophilic cytoplasm that if I said it's a liver mass biopsy, you would think of hepatocellular carcinoma, hence the term hepatoid. Things that have this reticular, microvesicular and reticular patterns, anastomosing cords in a loose myxoid stroma that makes it look yolk sac-like. And then some parts of the tumor can look just like conventional adenocarcinoma that you have no clue that there is anything enteroblastic about it. And these, what they have in common is that they all stain with SAL4, which is an embryonic stem cell marker, and they stain variably with markers of hepatocellular differentiation. So they'll stain with HEPAR, arginase, glypican-3, or AFP, but to varying degrees. And the reason to know about them is that they also are a tumor with bad prognosis. They're very aggressive tumors with a high incidence of liver and nodal disease and lymphovascular invasion. And I'll spend some time talking about it because it might be something that you see in your practice, and there are some clues that help you identify even without doing immunostains. So why enteroblastic? Enteroblastic because it looks like the fetal endoderm. So here's an example of a 9-week gestation fetus, and you can see this looks exactly, the tumors look or recapitulate the appearance of the fetal endoderm with columnar cells with vacuolated or clear cytoplasm on the surface. Vikram Deshpande, who some of you may know, who is in Boston, tried to bring some sense to this spectrum of tumors by saying we should classify them into type 1, type 2, type 3. Type 1 that look hepatoid and stain like a hepatocellular carcinoma. And obviously, this is not in the liver, it's in the stomach or somewhere else. This is a study not just of gastric enteroblastic and hepatoid carcinoma, but throughout the GI tract, including the pancreas. And then you can have tumors that look the prototypical enteroblastic with clear cytoplasm and stain with hepatocellular markers. And then those that look garden variety adenocarcinomas, but share at marker positivity for either AFP or arginase or HEPR1. The challenge is that tumors don't really follow the rules. So here's an example of the same patient. You can see the gastric mass biopsy, which looks just like any other adenocarcinoma, but stained just like an enteroblastic tumor. And actually, we didn't stain this one because there was no reason to stain it until it went into the liver. And you can see the liver metastasis looks like classic enteroblastic differentiation. So we stained this one and said, oh, it's an enteroblastic adenocarcinoma. And then we said, oh, well, the in-house biopsy was also done here. And we looked at that and it looks like conventional adenocarcinoma, and we stained that and it stains the same way. So the type 2 and type 3 and type 1 really is not very practical unless you start staining everything. So the reason to know about them is that one, whether it's enteroblastic differentiation or an adenocarcinoma with immunohistochemical positivity for hepatocellular markers, they tend to behave the same way. So we don't really have to do this type 1, type 2, type 3 because they have the same prognostic significance. And the reason to pick them up is because compared to conventional gastric carcinoma, they have a much higher prevalence of HER2 positivity. So there's a target associated with them, which can be very helpful. These are aggressive tumors which will behave poorly, but they can be positive for HER2, which gives our oncologist colleagues a target to treat. And as you can see, it's true for both hepatoid and enteroblastic carcinomas, and there's a minor subset that has NTRK alterations too. So there's some molecular underpinnings to this aggressive type, and we've seen at least a few that were disseminated stage 4 tumors at presentation that responded very well to either HER2 or NTRK-based therapy. So something to know about. So take-home points about enteroblastic gastric cancer: dismal prognosis. They have elevated serum AFP. So the WHO, because we couldn't have a classification that makes sense, has lumped all of these into AFP-producing adenocarcinoma. So the same thing that I mentioned about micropapillary, if you have a surgeon or your gastroenterologist colleague coming to you and saying, this was a 1 centimeter polyp in the stomach or a very superficial T1 tumor in the stomach, and the whole liver is studded with tumor and he has innumerable lung metastasis, you can be very smart and say, can you do a serum AFP? And in all likelihood, that's going to be elevated and it's going to be an enteroblastic adenocarcinoma. So that's a very simple clue that you're dealing with a morphological subtype that has prognostic significance. There's some data, very early preliminary data from China, that because they look like hepatocellular carcinomas in some ways because of the immunohistochemical positivity for hepar and arginase and even albumin-ish, maybe treating them like HCC may be helpful for these patients because there's not really much that we can do. So there's some data that sorafenib, which is a drug that we use in HCC, may be helpful in these tumors too. And then there are trials ongoing currently where these tumors also stain with Claudin-6, preferentially stain with Claudin-6. And there are trials looking at CAR T-cell therapy in this enteroblastic variant to see if we can somehow change the prognosis in these patients and identify targets that help us treat them. And then the last of the 4 differential that I mentioned, polydif squame, polydif adeno, polydif neuroendocrine carcinoma. And then the last in the group is undifferentiated carcinoma. So these are carcinomas common throughout the GI tract, also at other sites, that are barely carcinomas. If you did your pan-keratins, you can throw a panel of keratins, and you'll find, as in this case here, a few cells staining positively with pan-keratin. And this is a tumor type that loses this or arises as a result of mutations in the SWI/SNF pathway of genes, SMARCA2 or SMARCA4 or INI1. And INI1 is probably the least common in the GI tract. I think we've seen just 2 examples so far. SMARCA4A2, much more common in this undifferentiated spectrum. So the reason to recognize this phenomena is that if you have a biopsy and it's a small tumor to work with, and you throw a lot of keratin stains and it doesn't stain like a carcinoma or a lymphoma or a melanoma, think of an undifferentiated carcinoma. And that's most likely what the diagnosis is going to be. Abbas Agami from Germany put together the first series of the GI tract. These are examples from his paper showing this multicentric tumor in the small intestine. And then they have this, what they have in common is this loss of expression of SMARCA2 or A4 or INI1. The INI1, if you see an example in the GI tract, is most likely going to be a met from the lung, not a primary. So just remember that of all the 3 genes that I mentioned, INI1 is the least common. Let's switch quickly to molecular classifications of gastric cancer. There are several. The Asian Research Group cancer genome study that tried to subclassify them based on genetic aberrations. And then the Cancer Genome Atlas study, just like every other organ, you'll hear a lot about TCGA tomorrow also. They also did a series of gastric cancers, looked at it, not just sequencing, but RNA expression profiling, and basically try to classify them into 4 groups, which is very helpful, but more or less parallels the morphological classification. So the TCGA, every series, every tumor type that they looked at, they had roughly 200 or so cancers, and they did whole exome sequencing, looked at somatic CNVs, methylation, profiling, and so on. And then in the stomach, essentially, there are four classes. The first is the one that I showed you with lots of lymphocyte. Not surprisingly, that'll cluster separately. So the first group on genetic classification, if you will, is the EBV-associated gastric cancer. The second is, again, lymphocyte-rich MSI-high tumors or MMR-deficient tumors that will lose MLH1 or PMS2. And then the third important type is the genomically stable type. And if you look at histological correlates, the vast majority of these genomically stable ones are going to be the diffuse type gastric cancer signature cell morphology. And then the prototypical intestinal type that I showed you will fall in this big group of chromosomal instability tumors, which is the most common type, and will look intestinal if you looked at morphological correlation. So if you looked at what's most common based on location, what subtype or molecular subtype is most common, the intestinal type, most common because, as I said, that's the most common inflammation to metaplasia to carcinoma sequence. So it occurs almost everywhere in the stomach, most common proximally, but can be in the body or in the antrum. The genomically stable type, similarly, can be present anywhere in the stomach. The EBV ones most commonly are in the body, so they tend to spare the two ends of the stomach, the proximal and distal end. And then the MSI high ones or the DNA mismatch repair deficient ones are more common distally, so they don't occur to that frequency in the proximal stomach, more common in the body and the antrum. And if you look at prognostic significance, this is from TCGA, you can see that all the other types tend to cluster together except the diffuse type gastric cancer or the genomically stable one, because it has aberrant adherent expression on histology. So some molecular correlate of the histological classification that I showed you. But if you look at how gastric cancer is managed now, and this is the last 10 minutes that I promised you at the beginning of the talk, if you have early gastric cancer, those patients don't usually see any chemotherapy. Those are treated endoscopically. We need to know which patients among that group needs additional therapy and they need a resection of the stomach to stage lymph nodes. And we'll go through that quickly in a minute. And then those that are advanced, either deeply invasive into the stomach or have positive nodes or have distant metastasis as presentation, go through this algorithm of neoadjuvant chemotherapy followed by surgical resection. We won't go through endoscopic resections because I'm not sure how relevant that is in our setting here. For those who are interested, there's this very nice review by two of my GI pathology colleagues, Greg Lowers and Priyanti Kumar Singhe, who's in Australia, showing which are the features in gastric cancer that's early that can be used to say that the patient is now cured of gastric cancer. So the criteria basically depend on tumor size, histological type, and whether or not there's an undifferentiated component and whether you see lymphovascular invasion or not. So if a patient fulfills the criteria listed here, those patients don't really need a completion gastrectomy. For everybody else, just like in the colon, you can have a malignant polyp with cancer, and the main question is, does the patient need a colectomy to stage lymph nodes? The same question arises in the stomach. And then if you have a patient where you know this is a mass lesion that's deeply invasive, those patients will see neoadjuvant chemotherapy. And then you have a lot of options in your armamentarium, and what precise chemotherapy is given often depends on what biomarker status you report along with your histological diagnosis of invasive adenocarcinoma. So there are multiple markers we use currently. So the first one is PD-L1, which is a terrible marker to use, but it's established in practice. There's no easy way it's going away anytime soon, and I'll tell you why. The thresholds we use clinically is PD-L1 or CPS score, combined positive score, more than 1 or more than 5 or more than 10. We discussed a little bit about HER2 positivity. I'll show you some examples in a second. So this is the standard right now that we use in every gastric cancer mass biopsy that we get. So the first thing is to say this is an adenocarcinoma of the stomach. We usually sign it out without waiting for the biomarker. We'll just put in a note that biomarker ISC is pending. We'll report it in an addendum. And then when it comes out, these are this is the panel that we report MMR-IHC, whether it's intact or lost. If it's lost, which ones? If it's lost, is it clonal or subclonal? HER2-IHC, PD-L1, and then Claudin 18.2 is the most recent one that we've added about 2 years ago. So HER2, let's start with that. Why do we do it? Because there were trials showing that patients who are HER2 positive benefit from addition of trastuzumab therapy. This is the TOGA trial from many years ago, almost 15 years ago now, showing that those patients tend to do much better if you add trastuzumab to conventional chemotherapy. And then when you have this applies for GI in general. This criteria for colon are somewhat different. But in the stomach, you have to report or you have to use 2 features to decide whether you're going to call it HER2 1+, 2+, or 3+. So the first thing is intensity, which is determined by the so-called Rushoff rule based on the colleagues in Germany who came up with this, or the magnification rule. And basically what you're trying to see is whether you can see complete membranous staining, basolateral staining, or lateral staining at 5x, 10x, 5x, 20x, or 40x. So do you really have to go down on high power to look for positive staining? And if you do, that tumor is 1+ intensity. If you can pick up nice lateral membranous staining at 20x, that's 2+. And if it's very obvious at 5x, then it's 3+. And then you have to factor in extent of staining. And in the stomach, it depends on the specimen. So if you have a biopsy specimen, all it requires is a cluster of 5 tumor cells. So if you have 3+ staining in 5 tumor cells in a cluster, that's a 3+ staining, and that correlates nicely with HER2 amplification on a FISH assay or by sequencing. If you have a surgical resection specimen, then the quantification is slightly different, and you need that staining in more than 10% of the tumor cells. And it can be heterogeneous, and it can be hard because it's also based on intensity. So something that's we find very useful is to put the 3+ and 2+ controls on the same slide. So if you have a biopsy like here, trying to decide whether this is strong staining or moderate staining can be tricky at times. So if you have the 3+ control on the same slide and the 2+ control on the same slide, you can compare and say this looks more like 2+. And so this will not be called a 3+ at our institution. So there are guidelines from ASCO and CAP on how to report HER2, a reference that if you haven't read, you should. If you are trying to pick out a block for staining and it's a resection specimen, pick the lowest grade tumor because that's where the HER2 positivity is going to be most prevalent. If the tumor is very heterogeneous morphologically, it's okay to pick more than 1 block because there's a lot of intratumoral heterogeneity, and I'll show you an example in a second. And then if you're scoring something as 2+, it's very nice for you to mark an area that was 2+ on your biopsy for your cytogenetic colleagues who are going to report the FISH, so that they can then focus on that area when they're counting signals of HER2 and trying to decide whether it's amplified or not. So the reason I said there's a lot of intratumoral heterogeneity, and it has changed our practice in the past 2.5 years or so, is that if we have a case in which we already reported HER2 as negative and you have a subsequent specimen, either a metastasis or a recurrence, we always repeat the HER2 because it's possible that in a biopsy you missed the area where the positivity was 3+. So here's an example a few months apart, where there was a residual tumor that was biopsied after neoadjuvant therapy, and we suddenly saw that this is 3+ instead of the 0 that we had reported initially. We also see examples where our oncologists will call us and say, hey, this patient was seen here, you call the HER2 0 or 1+ on the biopsy, and it's now at MD Anderson or Mayo, and they are saying the HER2 is 3+. So don't be scared. They're basically looking at intratumoral heterogeneity. PDL1, as I said, it's a horrible stain to score because the way you score it is you have to count the number of positive tumor cells. The image on the left is very easy because you know it's positive because it's tumor cells that are staining. You also have to count the number of positive inflammatory cells in and around the tumor, which can be challenging, as you can see in the image on the right. And then you add them up and then estimate the total number of tumor cells at the denominator and come up with a CPS. And we showed in a very nice global study with the investigators from all across the globe that the CPS scoring is really very terrible. I mean, it's terrible, and it's very high inter-observer variability. And there's no way to meaningfully distinguish 1 from 3 from 5 and 8. The good news is that the oncologists now use it not looking for the exact CPS positivity, but looking at negative predictive values. So they really want you to tell them that this is CPS less than 1, so that they don't put through patients through immunotherapy, which has a lot of complications also. So we have shifted from oncologists pushing us towards a precise CPS cutoff to them saying, okay, we know that you are not good at doing this. We want you to tell us this is negative. So the likelihood of response in patients who have a CPS less than 1 is like 2%. So they don't want to put patients on immunotherapy if it's really low. Claudin 18, as I said, is the most recent kid on the block. Claudin 18.2 is used, positivity is used in many different ways, and I won't go through that. This is the Spotlight trial showing efficacy of zolbetuximab in Claudin 2 positive, HER2 negative, locally advanced tumors. And again, that has led to using this biomarker in routine practice. And this was the second big trial, the GLOW trial on Claudin 18.2. There are many claudins in the stomach. Claudin 18 is present in normal mucosa and in most gastric cancers, except the very poorly undifferentiated ones that I showed you. It can be expressed in other carcinomas, but very rarely. The most common extragastric one is probably pancreas. And then the cutoff that's used to call something positive is more than 75% membranous staining. The reason I said that the paradigm for treatment is changing is that there's already 2 targets that are probably going to be approved in the next year or so. Bemarituzumab, which directs therapy towards FGFR2b amplified gastric cancer, is probably going to be approved by the FDA in the US this year. So we are already validating our ISC for picking up FGFR2b amplified tumors. So this is the FIGHT trial showing efficacy of monoclonal antibody against FGFR2b amplified carcinomas. And the way we'll end up scoring these is, again, moderate to strong intensity, just like HER2. The cutoff is going to be somewhere around 10%. And again, these will change the way we approach gastric cancer that's locally advanced or metastatic at initial presentation. And then the last one, which is still in early stage, phase 1, is MTAP. So MTAP deletions are present in roughly about 5% of all gastric cancers and esophageal cancers. And there's data to show that MTAP inhibitors can have efficacy in solid tumors based on this trial, and also a recent one that was a phase 2 showing efficacy in gastric cancer. So you all are familiar with the CAP synoptic templates on how we report resections in gastric cancer, and this was this was how management of gastric cancer patients was determined in the past. And as I said early on, the way we approach it is changing, and all these parameters are, of course, important. But what's more important now is the biomarker classification of gastric cancer and what we do on the biopsy, because that determines upfront how the patient is going to be managed. So the neoadjuvant chemotherapy regimens are now tailored specifically based on the biomarker classification that we have in gastric cancer. And I'm sure that since there's a lot of molecular heterogeneity, there's going to be more and more markers being added to the list. So this is not really a classification in the true sense, putting things in different buckets, but from a patient perspective, very useful, because who cares whether the tumor is micropapillary or enteroblastic or not? They want to know whether it's HER2 so the patients can receive the right therapy. So this is how the writers are challenging the titans, because we used to think of addendum as something that's, at the end of the most important part, but that basically now is driving therapy in gastric cancer. So thanks for your attention. Happy to take any questions.